Hello, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Cancer Community Action Council. I'm Dr. Candace Lucas, and it is my pleasure to introduce today's topic and our amazing speakers. Community Conversations on Cancer is an education series designed to inform, educate, and disseminate best practices in research, clinical care, and community engagement to faculty, clinicians, researchers, and community members. Through this format, evidence-based perspectives on the continuum of cancer care and research will be highlighted along with the lived experience of our community partners and experts. Topics will address the social determinants, improving healthcare delivery, reducing health disparities, and increasing research participation from underrepresented groups in order to decrease the cancer impact across our 27-county catchment area. This month's discussion will focus on who bears the burden of cancer and how we align data and community priorities to address disparities in cancer care. This live event has been approved for 1 AMA PRA Category 1 credit and 1 contact hour for social workers by UR's School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. Throughout our presentations, please feel free to enter any questions in the Q&A box located at the bottom of your screen. If you would like a question directed specifically to one of our speakers, please include the speaker's name in the question. Today, we will hear from 3 esteemed speakers, Dr. Charles Kamen, Reverend Sebrone Johnson, and Dr. Deanna Fernandez. Dr. Kamen is an assistant professor in the Department of Surgery, Division of Cancer Control at the University of Rochester. He has a strong background in training in behavioral medicine, health disparities, and interventions for diverse couples and dyads. He leads the health disparities research effort in the Office of Community Outreach and Engagement. Dr. Kamen's research is focused on factors that lead to health disparities among sexual and gender minority populations, specifically disparities in cancer-related health outcomes and psychological distress. Reverend Sebrone Johnson is the senior pastor of the Greater Harvest Church in the city of Rochester and the senior vice president of operations for the Urban League of Rochester. He is a member of the University of Rochester Medical Center's Community Advisory Council and a member of the Wilmot Cancer Institute Faith and Community Advisory Board. He also serves as the ecumenical chairperson for the Rochester Black Leadership Commission on Health and the co-chair of the African American Health Coalition, convened by Common Ground Health, which recently released its report titled The Color of Health, spotlighting the toll of racism on the health of the African American community. Dr. Deanna Fernandez is an associate professor in the Department of Public Health Sciences. She is a nutritional epidemiologist interested in the two ends of the nutritional status continuum. Dr. Deanna Fernandez is currently focused on weight gain prevention and obesity in the United States. She has also served as the co-chair of the Latino Health Coalition convened by Common Ground Health for over 4 years and is ushering in the release of their coming report on the status of health of the Latino community throughout the Finger Lakes region. Today's discussion will be facilitated by the Cancer Community Action Council's co-chair, Ms. Karen Hermance. So with that, I turn it over to Dr. Kamen.
Thank you so much, Candace, Dr. Lucas. It is a real honor to be presenting alongside Reverend Johnson and Dr. Fernandez, and to share with you a little bit about how we can use data to better understand who bears the burden of cancer. And I think it's important to start out by saying we need to align data with community voices if we really want to be able to fully assess and address cancer-related disparities. So before I start, I want to give a thanks and shout out to the other leadership members of the Community Outreach and Engagement Office, Paula Cupertino, Francisco Cartagena, Claudia Burke, and Candace Lucas. We would not be here doing this work without their support and efforts, so huge thank you to them. Also, thanks to the data team that put together the data I'm going to be sharing with you today, Shuya Kai, Shan Gao, Yechu Hua, and Abdi Gudina. And all the data that I'm going to share was presented to the Community Cancer Action Council and was informed by the work of Common Ground Health through Jeffrey Freeman, specifically around the Rochester focus area that I'll be talking about later on. I want to start out with a question, and you can just think about the answer to this question in your minds. If I were to ask you, which state in America has the highest burden of cancer, which state would you choose? And by burden of cancer, I mean the most new cases of cancer in a year and the most people dying of cancer in a year. You might think of a state like Mississippi, right? Mississippi often ranks 50th out of 50 in terms of poverty levels, obesity, lack of access to healthcare, general deprivation. All of those are factors that could impact cancer-related health and people's ability to survive if they're diagnosed with cancer. And really the same is true for Alabama, Louisiana, Arkansas. You might think about a state like Colorado or New Mexico, which have the highest exposure to radiation of any state in the country. We know that exposure to radiation is a risk factor for cancer, and so maybe you would pick that as the state that bears the highest burden of cancer. Or you might think about a state like Kentucky, which year after year, study after study, has the highest rates of smoking of any state in the entire nation. This is accompanied by other factors like high rates of poverty and obesity, things that we see in Mississippi and other states, all of which could impact cancer risk and cancer outcomes for people in Kentucky. So if anybody picked Kentucky as the state that has the highest burden of cancer, you are correct. Kentucky does have the highest incidence rate of cancer in the entire country. Incidence rates are expressed in number of new cases of cancer per 100,000 people per year. And Kentucky has a rate of over 510 new cases of cancer per 100,000 people in Kentucky per year. And that is way higher than the number 2 state, West Virginia, which has only 482 new cases of cancer per 100,000 people per year. What if I told you that the area we sit in right now, the Wilmot Catchment area, this region, upstate New York, has an astronomically high burden of cancer. And in fact, if these 27 counties were their own state, we would have a cancer incidence rate almost as high as the rate of Kentucky, the second highest rate in the entire country, in fact. Does that surprise you? It definitely surprised me when I started looking at these data and tried to understand, what are the cancer-related issues for our region, and specifically why? why does this burden of cancer exist here in upstate New York? So I'd like to spend the rest of the time that I have to talk with you talking about what this region is, what the catchment area is, what the demographics of the people who live in the catchment area are. I'll share some data on cancer incidence and mortality in a little more detail than what I just said. And then we'll talk about the why, the risk factors for cancer, social determinants of health, and a little bit about environmental exposures. And then I'm really excited to hear Reverend Johnson and Dr. Fernandez talk a little more about how we can put these data into action. All right, so I've said catchment area like, 5 or 6 times already, and we haven't really defined what we mean by catchment area. So the catchment area for Wilmot is defined using data, and we defined it with a particular tool that we developed here at the Wilmot Cancer Institute called the Cancer Visual Analytics System, or CANVAS. This is a web-based tool. It allows us to take data and put it onto maps to visualize it. There's a public-facing version of this tool that gives data at the county level, and an internal data with protected health information that we can use within Wilmot to understand what's happening at the zip code level. The internal dashboard gets real-time updates from the medical record, so we can look at patient outcomes, and it supports people querying the data to be visualized in particular ways. The public dashboard is actually being revised right now, so I can send you the link to what we have currently, but it's going to look a lot better in a couple months, and I'll circulate the new link when we get it up and running. So using Canvas, we looked at who comes to the Wilmot Cancer Institute to receive care for their cancer. When we pulled all of the patient data from the past 5 years, we saw that we really do serve, as you can see in this map on the left, a large portion of patients from across upstate New York. A big concentration from Rochester, obviously, but really stretching all the way out to Albany. We also looked at who comes to Wilmot to be on a clinical trial. And again, we saw that we serve patients on clinical trials or cancer-related research from a big portion of upstate New York. Based on these data and this mapping, we defined our catchment area as being 27 counties in the Finger Lakes, Central New York, and the Mohawk Valley. Those 27 counties contain over 3 million people and cover over 20,000 square miles. And most of the patients we serve at Wilmot come from this region. So over 97% actually come from the catchment area. Here's a zoomed out map to show you where those 27 counties are in the state of New York. And you can see, as we were looking at where we serve patients, we do serve patients from all 27 counties, but the Wilmot Cancer Institute's care locations in the green dots are really concentrated on the western half of the catchment area. And so we partnered with the Bassett Healthcare Network, which has 5 cancer care locations in the eastern part of the catchment area around Cooperstown, to make sure that we could serve patients and also reach out to communities across this whole 27 county region. That's been a great, really productive partnership. All right, so now you know what the catchment area is. Let's talk about who lives in this catchment area. To define the catchment area, we used a bunch of different data sources. I'm happy to provide more detail about any of these, and they're all listed in the dashboard that I'll share with you all. But we use data from the census to understand demographics. We use a tumor registry called SEER, which is a national registry of cancers that documents who has what cancers in a bunch of states around the country. We used a state level risk factor survey called the Behavior Risk Factor Surveillance System to understand cancer related risk factors and behaviors. And finally, we used the Neighborhood Atlas to understand the Area Deprivation Index, which I'll talk about later on. So here's a really overwhelming table of data of demographics for our catchment area. And you don't have to read the whole thing. Just the general idea is that here we see the data for our catchment area, over 3 million people in these 27 counties, compared to the rest of New York State and to the United States as a whole. And I want to draw your attention to a couple of rows of data on this table. If you look at the whole catchment area, all 3 million people as a big aggregate summary, you might think, wow, we are not very diverse. We have just over 5% of the catchment area who identify as Latino and under 7.5% who identify as Black. And those percentages are way lower than the percentages for New York State and for the country as a whole. You might also think, okay, well, we're very old, right? We have a higher proportion of people over age 65 in the state and the country. And this is true. There have been many studies documenting that upstate New York is aging faster than the rest of the country. Younger people are leaving the small towns and even cities like Rochester to move to New York City or Boston and leaving older people behind. And so our age is increasing faster than the age of the rest of the country. On a positive note, you might notice that we have a lower rate of health insurance in the rest of the country and the state. So that means hopefully people could access care because most people in our region have access to health insurance. So if you look at the big picture data for the whole catchment area, all 3 million people, you might think we're white, we're old, and we have good insurance. But I would caution you that that is dangerous. Right? You can't stop with just the summary level statistics. If you really want to understand disparities and understand the communities that are most at need of intervention in a big region like our 27 counties, you have to drill down deeper. So let's take a really simple comparison and compare the rural to the urban parts of our catchment area. You can see here on this map that most of our catchment area in the blue and green is rural, so about 70% of the landmass is rural. But in red, you can see the urban centers, and there are 6 urban centers in the catchment area. Bonus points if you can name all 6. We have Rochester. I don't know if you can see my pointer. Rochester, furthest to the left on the top row. Then we have Syracuse, Utica, furthest to the right on the top, Binghamton, Ithaca, and Elmira, the smallest city in New York State, on the bottom. Outside of that, the area is very rural. 30% of the population lives in a rural region. And the issues confronting rural citizens are different than the issues confronting urban citizens. So urban individuals have, there's a higher rate of racial and ethnic diversity in our urban areas. And there is a higher percentage of older adults and people without a college degree living in rural areas. So even just looking at rural versus urban, we see differences emerge. But what if you drill down even further and look at one specific urban area and you look at the city of Rochester? Common Ground Health defined a Rochester focus area consisting of 8 zip codes in this heart of the city of Rochester. And we use this focus area to better understand the data about the populations living right in our backyard in our own city. When you look across these 8 zip codes, a very high proportion of Latino and Black residents, way higher than the percentages for the country or the state, and a lower percentage of people over age 65, and an even lower percentage of people with a college degree than we see in rural areas. So stopping at the big level of the whole 3 million people doesn't help you if you really want to intervene with a specific region like the city of Rochester. So it's important to drill down. Now that we understand who lives in the catchment area, let's talk a little bit about the cancer burden in more detail than what I described earlier. So I mentioned cancer incidence. This is the number of people per 100,000 people in an area who develop cancer in a year. And for the past 20 years, the Wilmot catchment area has had a higher rate of cancer incidence than both New York State and the United States. And interestingly, or I guess maybe troublingly, the rates for the US and New York State are declining in the past 8 years, but the rates for the Wilmot catchment area are staying the same or even increasing slightly. It's the same story for cancer mortality. This is the number of people who die out of 100,000 people in a region in a year, die of cancer specifically. And you can see that for the past 20 years, the Wilmot catchment area has had a higher rate of cancer mortality as well than New York State and the rest of the country. If you drill down a little bit and look at specific types of cancer, you can see that our region, the Wilmot catchment area, has a higher rate of 9 out of the 10 most common types of cancer in the country. They're elevated compared to the state and the nation. This includes breast, lung, and prostate, the most common cancer types, as well as more uncommon but deadly cancers like pancreatic cancer, all elevated in our region. But again, you can't stop at just that high level. You have to think about what communities, what people are bearing the burden of cancer in a disproportionate way. So here's the scary table with all those numbers, looking at the high level incidence rates for different types of common cancers. And if you look at the urban versus the rural parts of the catchment area, People living in cities have higher rates of breast and prostate cancer, while people living in the country have a higher rate of lung and colorectal cancer. Breaking this down by race, you can see that the Black community has a higher burden of lung, prostate, colorectal, kidney, and pancreatic cancer. While unique to our region, this isn't really seen anywhere else, the Latino community has a higher rate of lymphoma than the rest of the catchment area. That's usually not the case. So there are unique issues that you only can see if you're able to break the data down in particular ways. Cancer mortality, very much the same story. The rural parts of our catchment area have a higher burden of cancer mortality overall, and specifically a higher burden of lung and colorectal cancer mortality. And the Black community bears a disproportionate burden of cancer mortality, specifically with colorectal, pancreatic, prostate, and liver cancer mortality. Just to go back for 1 second, I mentioned the unique high incidence rate of lymphoma in the Latino population in our catchment area. And by using data, you can visualize what this looks like in a really unique way. So this map shows the zip codes with higher percentages of Latino residents. So let me stop that. So the darker the green color of the zip code, the more Latino residents live in that area. The red circles indicate the number of cases of lymphoma in each zip code. And so the bigger the circle, the more cases of lymphoma in that particular region. So by using Canvas, we can map where are Latino people living, where are their high rates of lymphoma, and we can drill down to specific regions that have high numbers of both Latino residents and high numbers of cases of lymphoma, so we can understand where to intervene to have the most impact on this disparity. And these may be zip codes with high numbers of Latino farm workers who could be exposed to agricultural pesticides that could then lead them to have a higher rate of lymphoma. But we won't know unless we look at the data and go to those areas to talk to the people who live there. All right, so that gave sort of an overview of the who, but we still haven't gotten to the why. Why is this cancer burden so high in this region, and why does it impact some groups more than others? I think the three things I'll talk about two first. Risk factors for cancer and social determinants of health are really important to understand when you think about who is bearing the burden of cancer. It's no surprise, given our overall high burden of cancer in the catchment area, that rates of cancer risk factors are very high compared to the state and the country. So our rates of drinking alcohol, our rates of smoking tobacco, our rates of obesity are all higher than New York State and the United States. Our rates of cervical cancer screening are a little bit lower. And so all of these could cause cancer rates to be higher in general. Breaking this down again by region, you can see that rural parts of the catchment area bear a really disproportionate burden of these cancer risk factors. There's a much higher rate of smoking, much higher rate of obesity and physical inactivity, and a lower rate of mammography in rural areas compared to urban areas. And finally, looking by race, the Black community has a disproportionately high rate of smoking and obesity. And just to put this into context, 27.5 is so high. The average smoking rate for the country is about 13%. And so this is over twice as high in the Black community. That's also unusual because in the Black community, there isn't always a higher rate of smoking than the white community in other parts of the country. I'll also draw attention to the 16.3% smoking in Latino individuals. This isn't higher than the white population, but it's higher than what we see in any other Latino community around the country. Usually Latino communities have lower rates of smoking than white communities do. And this high rate here in our catchment area, maybe because of a large number of Puerto Rican individuals who of all the Latino demographics have the highest rate of smoking. So again, you need to really look and get into the data to understand what's going on and who is really at risk for developing cancer. So I've mentioned smoking a bunch of times. You can map smoking to look at where geographically high rates of smoking are occurring. And you can see constellations of zip codes like this one here in central New York, where a chain of zip codes in a row all have smoking rates over 40%, which again, when you think of the national average of 13%, that is astronomically high. And then you can overlap rates of smoking with rates of tobacco-related cancers. So here in this map, the size of the circle is the number of, or the percent of the population that smokes, and the darker the orange, the higher the rate of tobacco-related cancers, things like lung cancer, esophageal cancer, head and neck cancer. By looking at the data this way, you can see there are definitely pockets where we should be concerned about high rates of smoking and also high rates of cancer co-occurring. And specifically, we can focus right in our backyard in the city of Rochester and this very high cluster of large circles and dark orange circle, indicating a lot of smoking and a lot of cancer. I think the question remains though, why? We've talked about where the data are pointing us to understand where cancer is the highest, but why do these disparities exist? In order to get to the why, we have to think about social determinants of health. You've probably all, maybe you've heard of the socioecological model, which I think is useful for us in thinking about why these disparities persist in our region. For an individual person living in the Wilmot catchment area, they are exposed to their own biological predispositions to develop cancer, their own behavioral factors like smoking, and their own psychosocial factors like stress that could impact their cancer-related outcomes. They also live in a community with a built environment that could change their exposure to different carcinogens. They're part of relationships that could reduce their stress or help to support them if they develop cancer. And they're also within a bigger society and system that could directly impact their individual health. If there are barriers to accessing healthcare, that could mean they get cancer at a later stage and end up dying from it. They could be exposed to structural racism and discrimination that could limit their ability to get access to high quality healthcare. And so all of these factors together need to be considered when we're trying to understand who is bearing the burden of cancer. Looking at the city of Rochester, which I highlighted a second ago, we can look at the area deprivation index for the zip codes in the city of Rochester. The area deprivation index is a summary score for the average income, access to healthcare, access to transportation, access to food in a particular region. And for context, a score of over 90 on the area deprivation index indicates an area is in crisis. And if you look at the Rochester focus area that we talked about before, these zip codes all have scores on the area deprivation index of over 90, indicating this is an area that is in crisis. It will probably come as no surprise to any of you that these zip codes also have the highest concentration of tobacco retailers of any zip codes in the catchment area. So tobacco vendors are targeting, in a way, because of various reasons, the poorest and most disadvantaged communities, which also then end up bearing the highest burden of cancer. I think probably nothing drives home the issue of social determinants of health better than looking at life expectancy by zip code. If anybody's played around with this tool, it's interesting and occasionally heartbreaking, but you can type in your address to the Robert Wood Johnson Foundation Life Expectancy Calculator, and it will tell you what your average life expectancy would be based on other people living in your community. If you do this in the city of Rochester, if you type in, for example, the address of the Pittsford Library in the village of Pittsford, you end up getting a graph that looks like this. So the average life expectancy for somebody in the village of Pittsford in that zip code is 83 years, which is higher than the average life expectancy for Monroe County, higher than New York State, and higher than the rest of the country. If you drive 10 miles away to the Arnett Branch Library in the 19th Ward, and you type in that address, you get a graph that looks like this. An average life expectancy of 67 years, lower than the average for the county, for the state, and for the country. So a distance of 10 miles predicts a 16-year drop in life expectancy. And this is social determinants of health. This is the socioecological model at work. This is how systemic issues at a broader level impact individual health and well-being. And we need to understand why some regions are disadvantaged so that we can intervene and specifically address any cancer-related disparities that exist in this one community versus another community. So I want to close with just a quick gesture to something we're just starting to do, which is looking at environmental exposures as another factor that could predict cancer risk. We've only dove into these data a little bit, so I'll just share a tiny bit of what we've discovered. We looked at Superfund sites and toxic release inventory sites across the catchment area. And both of these measures in the map on the left, in the green and purple, show concentrations of chemicals in the groundwater and the ground that could increase cancer risk. And you can see there are definitely high concentrations in places like Elmira, more rural areas, but high concentrations in the city of Rochester, very high concentrations. Same thing is true for air pollution predicting cancer risk. This map on the right shows predicted cancer risk based on exposure to particulate matter in the air. And again, you can see some zip codes in the city of Rochester with very high exposure to pollution, which could produce higher risk of cancer. We're hoping to use these data and overlap it with other demographic data that we have to better understand how exposures could play into this whole picture of cancer disparity. And, Kodak has been a part of the fabric of Rochester for many years, and who knows what impact industrial waste and runoff has had on our cancer risk as a city and as a broader region. We're only beginning to kind of parse that out. So I'm really excited to turn it over to my community partners. But in conclusion, the points I would leave you with are data are fantastic. Data can help us to characterize the cancer burden. Data can help us to understand issues that confront a broader community. But data do not provide answers without interpretation. You can't pull up a data set and expect it to tell you what you need to know. You need to ask the right questions, and you need to drill down to really understand specific issues at the community level that are relevant to all of us who are trying to reduce the cancer burden. And finally, data without action is useless. If you listen to this talk and you think, wow, that's interesting, there's such a high burden of cancer, and you walk away and do nothing, then what's the point, right? The point of data is to cause people to have a plan for action and to know how best to intervene to address problems. So with that, thank you very much for listening. I'll look forward to all of your questions, and I will turn it over to Dr. Fernandez and Reverend Johnson.
Well, thank you so very much for that, Dr. Kamen. And certainly thank you, Dr. Lucas, for allowing us to share some thoughts on this matter. I love Dr. Kamen's approach in that presentation of giving us disaggregated data so that we may be able to drill down further and see the truth of the story. In addition to serving as co-chair of the African American Health Coalition, I serve as a pastor and also as an operations person at the Urban League. And I want to bring that out because of this. My church sits in the 14613 zip code. The work I do at the Urban League is based in the 14605 zip code. Two areas that consistently show high poverty and high mortality. In 2014, the leading cause of death in Monroe County was cancer. Just prior to the COVID outbreak in 2019, the leading cause of death in Monroe County was cancer. And a demographical study of cancer risk factors, including drinking, smoking, obesity, physical inactivity, and screening, some of which Dr. Kamen mentioned, it tells the story that while there is much medical work to do to eradicate the disease, there is also so much socioeconomic work to be done. And that work includes the fight against racism. We have to attack systemic and structural racism because racism leads to some form sooner or later of redlining. And redlining at its core draws these zip codes upon which we use those to keep some people at bay. It discounts individuals from living in resource-rich environments, relegating them to densely populated resource scarce areas with barriers to quality lifestyles and accessible healthcare. This then creates a sort of petri dish of poor health outcomes, and it allows the consistent number one killer to breed. That killer again, cancer. A study done by the University of Wisconsin showed that 40% of health is determined by socioeconomic factors like education, income, community safety, et cetera. 10% is determined by the physical environment. 30% determined by health behaviors, including smoking, alcohol, diet, and exercise, and another 20% by access to quality health care. Well, when racism produces a poverty that places you in substandard living conditions, that leads to unhealthy behaviors with reduced access to healthy food, and also reduced access to healthcare centers and healthcare information. And so we get the results that were just presented to us. Common Ground Health recently released its report, The Color of Health, the devastating toll of racism on Black lives. It documents how racial bias in housing and education and in employment and criminal justice and even other domains condemn Black people in these same problematic zip codes to sicker and shorter lives. Structural racism is literally stealing the breath from our community. It's behind the deplorable higher rates of COVID infections and mortality for Black people. It's behind higher rates of heart disease, diabetes, and asthma. It's behind more Black mothers dying in childbirth and more Black men dying of violence. And yes, it is certainly behind the high incidence of cancer. The report shows how biased practices, whether deliberate or unintentional, limit access to well-paying jobs, safe neighborhoods, nutritious food, and healthcare, how segregated neighborhoods and schools limit opportunities that are foundational to a child's future wealth and health. And it shows how chronic exposure to racism has a weathering effect on the mind and body and their ability to stave off disease. I quoted about that report that health shouldn't be Black or brown or white. It should not have to be a color at all. It should be a liberty, an expectation, an assurance, but not a color. Sadly, I think that we're finding that cancer also has a color. And so the African American Health Coalition tries to utilize diverse organizations and networks and individuals to help our community prioritize racial equity and support anti-racist strategies and policies to improve overall health outcomes. We need healthy stores everywhere. We need access to healthcare systems and buildings everywhere. We need health information everywhere. And to that end, the coalitions will try our very best to disseminate this information and continue the clarion cry to make sure that all zip codes are worthwhile living in. And our hope is that in 2025, when we examine zip codes again, it will finally tell a different story about cancer in our community. I'll stop there, and I can't wait to talk to you further about this, but we have to do more, and I believe in our community, we will do more. I'll turn this over now to Dr. Deanna Fernandez to have a conversation with us as well.
So I'll start again. Thank you, Reverend Johnson and everyone else for giving us the opportunity to discuss racial ethnic inequities in our county. I am the chair, the co-chair, or the outgoing co-chair of the Latino Health Coalition. This is the last month. I'm a co-chair. Reverend Johnson has said almost everything about the reasons for inequity in many health outcomes, in this case in particular cancer. I think we all here know that race and ethnicity are not biological risk factors for disease, they're social constructs. So when we talk about race, the differences in race and ethnicity, we are talking about the social determinants of health, the characteristics of where we live, where we play, where we work, that puts us, some people, at higher risk of developing diseases or not being as healthy as other people who don't share those social determinants of health. And in our case, they are pretty, these redlining affect mostly African American and Latino people, but there are differences, however, between the two groups. Although Latinos come in all colors, right? I am a Latina, mostly with European influence, so I don't have a difference in color with other white Americans. And for me, up there's all shades of color of skin, and colorism affects Latinos too. We tend to call it colorism more than racism. I think it has other implications in this context in the US. And that's what our coalitions, the African American and the Latino Health Coalition, concentrate our work in those social determinants of health. So I wanted to point out some interesting data about Latinos. And also the difference between African American and Latinos in terms of cancer. You've seen in some of the slides that Charles Kamen showed that there are incidents. The incidence of most of the cancers, except for lymphoma, is lower among Latinos than it is among African Americans. It's almost the same or sometimes lower than among whites. So you can tell, you can ask me, why are we complaining about? So if you look at some data for some cancers, though the incidence among Latinos is lower, and the years of potential life loss too, that potential life loss, years of potential life loss is a measure of premature mortality, meaning that how early do you die? And it is compared with the life expectancy in the population. So if the life expectancy is 75 and you die at age 35, you have 40 years of potential life loss. If you die at age 75, then you have 0. So in our case, among Latinos, with certain, there's a lot of layers, of course, in this issue, but both the incidence and the years of potential life loss are not as bad as it is for African Americans, and sometimes the same as it is for whites, and sometimes lower. However, for every person who's diagnosed, say, for lung cancer, the probability of dying is higher among Latinos and also among African Americans compared to whites. That's where a lot of the social determinants of health play a role as well. What happens, there's 3 people who are diagnosed with the same cancer, and the African American person and the Latino person will die more likely than the whites. It's a difference that we don't mostly talk about, but what's happening? Are they diagnosed later? Meaning that if you don't have access to healthcare, or you don't have a good support system, you don't have a screening necessary to diagnose your cancer earlier. And we know that for the most part, the earlier to diagnose cancer, the more likely to survive. What is the reason why we Latinos, although our incidence is lower in many cases, we're more likely to die of that cancer? I can give you an answer to it, but it does point out to really a difference that we need to tackle. We need to understand why those happen. It's also interesting to understand that the effect of socioeconomic status is more acute among, it's different among African Americans and Latinos. If you look at cancer mortality, for example, on average, and socioeconomic status, the better socioeconomic status Latinos have, the lower the mortality due to cancer. that doesn't happen with, compared to whites and African Americans, correct? That doesn't happen with African Americans. The differences in mortality among African Americans persist at all levels of socioeconomic status, which points out to the effect of racism much stronger about African Americans and among Latinos. I wanted to point out to two things that come up in the Latino Health Coalition conversations, which are not applied only to cancer, but in general to health, to our health status. One is, and to access to healthcare. One is language access and cultural competence. And the other is the role of family in Latinos' life. I don't remember off the top of my head the numbers, but there are a large percentage of Latinos who don't speak English or whose English proficiency is not as good. And there's no language, Spanish services, not that many. So this have been discussed a lot. We had a Latino round table the other day at Summit, and it was pointed out that it's not enough to have a receptionist who can say hello and thank you and goodbye in Spanish. We need to have language access at a higher level, and also at the level of the point of care who's serving this Latino person. The same as the cultural competence needed to make someone feel that they're being taken care of, that really affects the outcomes of many health conditions. And the other one that has to do with cultural competence is the role of the role of families for Latinos. We come with the family included. My husband is from the US, and I told him when we started dating that Latina women come with the family, that there's no difference, that if he accepts me, he has to accept the family with me. There's no other way. And in this culture, once you turn 18, families are excluded. You really have to fight your way as a family member in the healthcare of your loved one, and really affects the quality of life and the quality of care of the patient, and also the quality of life of the family. And we are there. It's like that. And I think for practitioners, and this should be taken into consideration, including the families. In the families in the announcement of cancer diagnosis, the families in the decisions for treatment, in the care. It affects our community significantly. So I'm looking forward to questions and discussion. Thank you very much.
Thank you for that incredibly interesting presentation. As a reminder to our audience, please enter any questions that you have for our presenters into the question and answer box. We will try to answer as many questions as we have time for. And great presentations, and thank you all so much for sharing that information. So the first question that I have is for Dr. Kamen. Dr. Kamen, with such a high burden of cancer in the catchment area, are there particular cancer types that you are focusing on in Wilmot's cancer control work? And do they vary in each county?
Bless you to whoever asked this question, because I meant to mention this during my presentation and it completely slipped my mind as I was going through the many tables. But yes, absolutely. We do have some priorities within the Wilmot Community Outreach and Engagement Office for particular cancers that we're trying to address. Really, there are three. One, tobacco-related cancers, which has a really high burden across the entire catchment area, as you saw. The second is lymphoma and leukemia, We call those hematologic cancers. And those disproportionately impact Latinos, as you heard, but also are really high in older adults over age 65, higher than in older adults in the rest of the country. And then the third are pancreatic and hepatobiliary cancers, which disproportionately impact the Black community in the catchment area. And so those are cancers that we're focusing on, both because they have disparities associated with them, and also because we at Wilmot have expertise in working with those cancer types. And so we are positioned to be able to make an impact on those disparities. There was also, Karen, if I can jump in, another question that I answered with text, but I want to briefly say it verbally. Umangata asked if the higher burden of cancer could be related to better quality of care, people migrating to care centers that could help them. And I think possibly, I think it probably, if that's one of the reasons why we have a higher cancer burden, it's probably because we have more insured populations. So we have more people who are getting cancer screenings. So we end up detecting cancers earlier and better than other regions. That is a possibility. But despite that, we still see a high rate of cancer mortality. So those high screenings and detection of cancers early aren't helping us to survive. So there's more to unpack than just that explanation.
Thank you, Dr. Kamen. We have another question for Dr. Fernandez. Doctor, does your coalition work with migrant worker populations or city residents only? And what do they do?
No, mostly because it's where the major concentration of Latinos we have. Although there is statistics saying that there's a slow migration of Latinos from the city to the suburbs lately. There's still, as you see in the numbers, there's more Latinos in the city than in the rest of the catchment area. And we do include Latino farm workers. Most of the farm workers in our area are Latinos, particularly from Mexico. Their participation is more difficult, but we are trying to include them. And in our report, our Latino health report is going to come out probably by the end of the year. I think it's the first time that we include data from about farm workers, although there's not a lot of data about farm workers for many reasons. One of them is the access to healthcare and documented status. People don't want to disclose themselves as just as being here. Yeah, and what do we do? It was the other question. Was that?
That was the question.
What do we do?
I have another question for Reverend Johnson. Reverend, how are you working on access to healthy foods in the city?
Well, we're working in a number of ways. Firstly, our advocacy against food deserts, and so that we find ways to get individuals access to grocery stores that have fresh fruits and vegetables at prices that individuals can afford. The Urban League certainly partners with a number of programs trying to do this, but we also are looking at growing our own healthy foods in various parts of the city. And we're doing this with students. And so we're allowing young people to understand what it takes to grow healthy foods, what it looks like, and those types of programs. But we're also working with Food Link and some interesting things. We don't know how this may pan out, but we're in early discussions of how we might start some not-for-profit grocery stores in the various areas. And so therefore the community actually has agency in the stores that serve them best. We've seen that many of the chains that we've had for years and years are moving further and further away from the city, and they're starting to be relocated in suburban areas and even areas outside of Rochester, New York State, further deprivating our areas of most need. So instead of just solely looking at getting those stores and chains to come back, we're trying to take control by making our own access available. Hope that answers the question.
Thanks, Reverend Johnson. We have a question for Dr. Kamen. Dr. Kamen, do you find that the relocation of young people away from the Rochester and the general Wilmot catchment area has affected the care that older populations receive on their overall health?
That's a really interesting question. I think it hasn't, at least within Wilmot's network, negatively affected older adults getting cancer care. We're one of the very first cancer centers to have a geriatric oncology program. And so Dr. Supriya Mohili, who's an investigator at Wilmot, was one of the founders of the Cancer and Aging Research Group. And she has an incredible consultation clinic called SoCare that serves the entire catchment area, and that with a consultation model allows for older adults with cancer to be seen by her team. They assess their age-related concerns, things like cognitive functioning, falls, nutrition status, muscle wasting, to make sure that those are being addressed alongside cancer-related concerns. So I think actually, ironically, we're getting better care for older adults with cancer patients in the catchment area. But I think the bigger question is really good. You know, what is the long-term impact going to be of having a young workforce move out of the region? And since we're already a region that has a high burden of poverty in certain areas, what's that going to mean long-term if the workforce ages into retirement without enough young people to replace it? And that's a question I don't really have an answer to.
Thank you. I have a question in general. This one might be for Reverend Johnson. I'm trying to reach to the African American in Batavia, and I'm finding it very hard. What advice can you provide for cancer screenings like cervical, breast, and colorectal?
So let me, I just dropped my email address in the chat for you. So email me separately to find out exactly the types of things you're looking at in the community you're looking at. One thing I'll just say is that there really is no such thing as the African-American community. It's the African-American communities. And so because there are so many different communities that make up what we call African Americans, I would really have to dig a little bit deeper in terms of what part of Batavia, what are you trying to get at? But I can definitely talk with you offline and get you to the place you want. Hope that helps.
Thank you. I have a question for Dr. Kamen. Is there any correlation being looked at between any of the current research focused in drinking habits, obesity, or any of the other risk factors?
Yeah, we have really been developing our cancer prevention work, which our Cancer Institute has a really strong cancer control program, and that mostly is working with people who already have cancer patients and survivors. But we've really been developing cancer prevention with Dr. Paula Cupertino kind of at the head of it. And her work looks specifically at smoking in Latinos as a risk factor for cancer, and how we can use cultural tailoring and accommodation to make sure that interventions to reduce smoking are appropriate for the Latino communities. And I think it's important that Reverend Johnson brought that up. There are many Latino communities, and you can't have one size fits all for even an intervention translated into Spanish. So that's one thing we're doing. We've also been doing a lot of work with cancer screenings because, you know, again, with the big picture data, you may think that screening isn't a problem in our region, but there are specific communities that don't get cancer screenings at the rate that we would want. And so we've been working with emergency medicine departments to try to use emergency medicine as a place to get people who are not compliant with cancer screenings to engage with screening and get them when they're recommended by guidelines. So those are just a couple of examples of things we're doing in that kind of risk factor space.
Okay, thank you. Is there any data on the use of marijuana, especially using cigar paper on a cancer-related diagnosis?
It's a very interesting question. I think, and I apologize, I just actually clicked that we answered a question that I didn't actually answer. So we can maybe, oh no, we did answer that one, never mind. We're good. Yeah, I don't know. I don't know of any data about marijuana use and cancer risk specifically. Inhaling any combustible could increase your risk of cancer because you are inhaling particles into your lungs, which could increase inflammation of your lung cells, which could increase the risk of them mutating or dividing poorly and becoming cancerous. But I don't know if Reverend Johnson or Dr. Fernandez, you have any data on marijuana and cigar paper specifically?
I don't.
No, but I think it's a really interesting question that bears some investigation, particularly with some legalization concerns that are coming up. And so I think that that's an area of focus that we have to look into soon, because you're right, that combustible, which may have been in minority use before, may become majority use pretty soon. So we need to look at that. That's a great question, though.
And I think the same question applies to vaping in general, vaping for tobacco or for marijuana. We don't know what the long-term cancer risk is. We think it's less than combustible cigarettes, but we don't have enough data.
Also, vaping starts earlier in life among adolescents, so we don't know the long-term effects of it.
Dr. Fernandez, can you say that again, please? I didn't hear that.
Vaping is a large burden among adolescents, and so if you start early in life, then you have a longer exposure, and we do not know what the lasting effects of vaping is.
I can make a comment really fast, Karen. I was just so struck, Reverend Johnson, by how you summarized basically the whole big ticket picture of this, which is it's hard to imagine that something like racism can directly cause cancer. But when you think about things like redlining, higher percentage of tobacco vendors in an area, higher exposure to pollutants, less access to healthcare, it makes so much sense. Racism does directly impact our health and can impact cancer. It's not just biology, the system matters too.
Okay, we're gonna thank you very much to all the presenters, Dr. Kamen, Reverend Johnson, and Dr. Fernandez, for sharing your data and thoughts on this critical topic of who bears the burden of cancer. Please take a moment to fill out the survey, which helps us select future topics of importance to you. A record of today's community conversation will be sent to all registrants early next week. Our next community conversation is scheduled for May 13th at 12 p.m. discussing tobacco use and lung cancer. We hope to see you all there. Thank you very much, everybody.
Thank you.